Hey, Erin, Tanisha wants to know if you could record this because she has some issues going on with her kid.
Okay. Yep, I've got it recording now.
All right, thank you.
Uh-huh. Give you guys a couple more minutes, see if we get any more people kind of arriving. All right, we're gonna go ahead and get started because I know it's kind of a later evening for this. Can everybody hear me?
Yes.
Thumbs up, good, okay. So I was trying to figure out ways to ask questions and get responses, and Poll Everywhere does a really good job, but I do have to do screen when I do it. So in this unit, we're really covering a lot of our different emergencies. And so the first week we were working on traumas, really covering, and traumas cover a really vast range of everything that happens. And so I kind of wanted to know what you guys think of when you think of trauma. And so, you know, we're looking at the words. I see severe, rapid, different, you know, changing, wounds. So, you know, putting all those kinds of things together when we're talking about traumas, they have a huge, huge impact on people. They have a huge impact on the finances of what's going on. So that's something to think about too when you're talking rehab, different severities of traumas. So that's something to kind of think about, that like we you know, you guys, you see the blood, guts, and tears of like the TV shows, you know, the emergency in the ERs, all that kind of stuff where the traumas are huge in there. But what we don't see a lot of is the after, that traumas take months, if not years, to heal from. And you guys are going to get to see a lot of these patients because you're going to get to see them in the rehab facilities. You're going to get to see them in the clinics when they come back. You're going to get to see them in the hospital when they're there. Most of them are going to come in through the ER, but when they go to the hospital, potentially are going to go to the ICU, depending on the severity, and then they're going to go to med surge, general care, whatever, and then rehabs and on. So you may see them as home health patients. I mean, just a huge, huge variety of where you're going to see them. And, you know, again, on that spectrum of healing, because healing doesn't happen. It's not like you get an injury and all of a sudden you're healed. The healing is a process. So trauma causes a lot of really drastic things to happen. And that's something that we need to be able to pay attention to. There is also emotional trauma that comes with trauma. There's the physical part, and then there's the emotional part. So make sure you're keeping that kind of in your head too. I've worked with a lot of patients who have had, like, they have nightmares. You know, we get them healed, we get them past the scary part, you know, the intubated, whatever. And now they've got to deal with every time they think they're going to sleep, they're scared they're going to be in that again. So it's something to kind of keep in mind. Stop screen share here. So, Gabe. See if I can switch in and out of this a little bit easier here. What kinds of questions do you guys have for me? And if you don't want to say them, you're welcome to put them in the chat section. Where are you guys in your understanding of what's of traumas? Or what questions do you have? I said this was going to be really student-led, so.
On the pre-quiz, when it came to the multiple select question of what types of trauma are there, I was really confused by that question.
What types of shock?
Was it, yeah, shock.
Shock. Okay, so there are, for a second. Oh, let's see. I can do speaker view so that, no. Missy, I'm gonna mute you.
Oh, I'm sorry.
You're okay. Because it picks up, I think, anybody that's not muted. So if I can do, try and figure out how to make me bigger so I'm not super tiny in the video. But no, I don't know how to do it. So, okay. So when we're talking about shocks, there's a variety of kinds of shocks, and we're going to go into shock more next week in the lectures. But yeah, there's definitely some different kinds. We talked about, I mean, you guys have probably, oh, that marker's not going to work today. Septic, which is the shock that we get from infections. Oh, I hate that light. There is neurogenic, which we don't see a ton, but that's when we get shock from spinal cord injuries. There's the shock from hypovolemic, which is the shock that happens when we lose too much volume. And we can lose volume slowly or fast. You can have patients, like think about, you guys have done renal failure. What's something, when somebody's on dialysis, what's something that they're really paying attention to?
Their fluid intake and output.
Yeah, they're really paying attention to the fluid, right? Because they're worried about them going into some sort of hypovolemic state, right? They're worried about them losing that volume, okay? And so Aja asks, what's neurogenic shock? Neurogenic shock is spinal cord injury, okay? And I'm gonna make a video this weekend. It just got cold and I ran out of time, but that kind of goes into shock a little bit more, because shock is really like, I've got a video up there for you guys to watch. That's kind of the scientific view of what shock is. But shock is really simple. It's either there's a problem with the pump or there's a problem with the hoses. And so you have to figure out which is the issue, and then you've got to fix it, okay? So that's when we go into a little bit more about shock. All right, so we will go into more shock, but we're gonna kind of push that off for next week. It is something that we're really worried about with trauma. What types of shock do you think we're worried about with trauma?
Like toxic shock.
What is toxic shock? What's the base of it? What do you think are the two most?
Septic shock?
What?
Were you thinking septic shock?
Yeah. So septic shock and hypovolemic shock are probably the two types of shock that we will see the most often in trauma patients, right? They've either been drugged through the street, so they get septic, or they've lost too much volume, and so now they're hypovolemic, okay? And so those are the two bigger shocks that we really worry about. Neurogenic, again, that's spinal cord injury. And so again, it causes a vasodilation and causes a problem with the hoses. So it's a miscommunication because the nerves are severed or damaged.
Erin,
Yeah.
so the hemorrhagic and the hypovolemic are the same thing. It's loss of like bleeding. Okay.
Yep.
That's-
Hemorrhagic shock would be from loss of blood. Hypovolemic is just loss of volume. So it could be blood. It could be like your dialysis patient that all of a sudden codes while they're getting dialyzed because they had 3 liters taken off, and so
Yeah.
they can't handle it. It could be your patient that's been in the desert or that got stuck out in the sandhills for too long and was camping and no one knew they were missing and they fell or something, and so they got dehydrated. That can cause a hypovolemic shock. So, you know, when we talk about these kinds of things, that's what we're really worried about. So I can't remember what was the other one that I had on there because there's just,
Yeah, hemorrhagic, neurogenic, and septic.
yep.
Yeah.
So, yeah.
Wasn't there cardiogenic on the
hypovolemic.
visit?
Yeah,
Yep.
cardio.
Yep, and then
Cardiogenic.
cardiogenic shock, and that's a problem with your pump. So, and you'll see cardiogenic shock a lot of times after heart attacks. I think I've seen cardiogenic shock one time in my like 8 years of ICU, but I just didn't work with hearts. So that's kind of what I've seen. But, and if you get cardiogenic shock, you've missed a lot of other symptoms. So what other questions kind of focusing on trauma? Where are we at with our understanding? What makes a trauma?
Any like disruption in A, B, C, or D?
Okay, so you're talking about the primary survey. So we're talking about, so A, B, C, or D, airway, breathing, circulation, or disability. Probably one of the biggest things I see with trauma, guys, is everyone wants to go right to the bleeding. All right, everybody's like, ooh, I got to stop the bleeding. Guess what? If they're bleeding, they're pumping. So if they're bleeding, I leave the blood, I got to go to the head, I got to check that airway. Okay, I got to check, you know, and that's what we talked about first. And I know the quiz got all wonky. I did it just today when I made your guys' ABG quiz, and it added random blank answers. So I went through and hopefully those are figured out. But safety is always, always, always first. Okay, you put the air mask on you before you put it on your kiddo. You put, you know, you got to get yourself safe before, you know, you got to get yourself safe before you can get someone else safe. So if you go after someone who's drowning, they're going to grab onto you, they're going to push you under. So you got to keep you safe first. So when it comes to trauma, safety is a huge piece. Some of the things that we have to worry about, you know, I mean, just safety of the scene. I've been a first responder on 2 car wrecks. I'm trying to think. 2 car wrecks mainly. One was a pedestrian versus car on Dodge Street in Omaha. Did not do well for the pedestrian. Don't walk across Dodge Street drunk at 5 o'clock at night. And then the other one was motorcycle versus SUV, which again, did not bode well for motorcycle. SUV is a lot bigger, has more impact. So, but I had to make sure the scene was safe. I didn't do a really good job when I, on Dodge Street, I kind of darted across the street, so still not safe and still not very smart, but I was young and dumb. So making sure safety is there. Let's see. And then like the SUV, that one was that she had been flipped over into the grass into the over the guardrail. So I didn't have to worry too much about safety at that point in time. But my other safety then is like, do I have gloves? I don't have gloves. I don't carry gloves with me in the car. I should. Even if I did, I probably wouldn't take the time to grab them. So it's like, unless I have them in my pocket, I'm probably not wearing them. So again, safety for me, making sure I'm safe there. I didn't do breathing on either of them because I didn't have an air valve mask, and I'm not about to put my mouth on someone else's. The one lady that was a pedestrian versus car, I wouldn't have been able to breathe for her anyways because it was her head that impacted the windshield. So probably not getting a good sealed airway on her. But the other lady, she wasn't bleeding. So what does that tell me when they're not bleeding?
When they're not outward bleeding?
Yeah, they're not pumping. Not bleeding means not pumping.
Yeah.
If you're not bleeding after you've been hit by a car, you're probably not pumping. Her feet, the motorcycle versus SUV, her feet weren't attached. She should have been bleeding, and she wasn't. So so I actually didn't do a lot with her, other than checked her and pretty much called her time of death. But and then helped the husband as he sat next to her. So like that was something that had to transition. You know, you go from there wasn't any taking care of her that I could have done at that point in time. We were 4 hours from any civilization. And so there was no, like I did ABCD and there was no coming back from it. So then my care focused to her husband who was like witnessed and was there. So with the other one, the pedestrian versus car, okay, so safety, didn't do a stellar job on safety, kind of darted across Dodge Street. Airway, I rolled her over, so should have probably held her C-spine, okay, to keep her airway, or to keep everything, but I rolled her over and she was breathing. Okay, so I've got an airway, she's breathing, she's bleeding, so I know she's got circulation. Then I kind of have scanned her over, and my biggest thing, honestly, at that point, because she was pretty well crushed, was kind of maintaining that airway. And I just did that, the jaw tilt, the jaw lift that you do in CPR class to try and maintain and hold her airway until the ambulance and stuff was there. So you do all those things. I think someone came up and asked me what was going on. And I said, has anyone called 911? Of course, lots of people had, thank God, people who knew where we were. I'm in Omaha, I don't know where I am usually. So those are kind of the things that we're gonna pay attention to with trauma. Safety always first, then airway, breathing, circulation. And that D is for disability. That's when we're starting to look at broken limbs. That's when we're starting to look at bloody stuff. And then you can go through the rest of that survey. But a lot of times, most of that comes from at the hospital or comes as you're getting people checked in, okay? So those are kind of our first things that we're gonna work with when we're going through a trauma, and that's something that we're gonna see. So that being said, I think I have another poll everywhere question. Let's see if I can pull it up easy. When I'm on my laptop, I don't have nearly as much ability to move around. Okay. So here's kind of your next question. A person is brought to your clinic that has just got into a car wreck. What questions do you want to know? So they're being brought to you. You work at a clinic. This isn't an ER. This isn't a facility that's used to handling this. What kind of questions do you want to know? Okay, what time it occurred. So how long have we had this car wreck? Vital signs and which damage? LOC, what does LOC mean?
Loss of consciousness.
Not loss of consciousness, it's level of consciousness.
Level.
There you go, that level of consciousness. But it's definitely important for us to know, did you hit your head? So we're getting into those head trauma questions, okay? Again, really important to ask about that injury. What kind of injury do we have, all right? Did you do CPR? If you did CPR, hopefully they're not coming to a clinic, but definitely important, because I'm gonna tell you guys now, when you do CPR, very, very, very rarely do we get somebody back to a sustainable rhythm without shock and meds. So we're not usually gonna do anything, okay? What meds are they on? Let's get into an important question. When we start talking about medications, why is it important for us to know medications that they're on?
To see if there's like any contraindications, or if they're on like an an anticoagulant and they're bleeding and
Yeah. So when we start talking about medications, when we start talking about head traumas, especially head traumas, if they are bleeding, if they are on an anticoagulant, we can't reverse all anticoagulants, nor do we want to reverse all anticoagulants. If we reverse an anticoagulant, a lot of times what happens is now we are going to let them clot up. Okay, well, that's great for the bleed in the brain that they've got going on, but that's not great for the reason they were on the anticoagulant in the first place. They were on the anticoagulant in the first place because of their AFib, because of they've had a history of stroke, whatever, and now we're going to end up letting them bleed. So it's that fine line, which is going to get them. If we give them, if we reverse that anticoagulant, are we going to end up having them having a stroke because we anticoagulated them? Now they're making clots, and now they're shooting those clots up to the brain. Okay, so it's this really big catch-22 of how do we work with these patients that are going through this. Okay, other meds we might want to know. Beta blockers. If they're on a beta blocker, what if they're already on opioids? Okay, traumas do not come in like clean and sober. A lot of times traumas come in with alcohol, drugs, all sorts of other things on board. Okay, so that's always a good question for us to ask. The other thing I like to know is, how long did it take? How long did it take to get them out of the car? Okay, because that extrication, if it takes a long time, if you're squished in that car and you have that steering wheel like pushed up against your chest and it takes 10 minutes versus an hour, there's a lot more damage that can be done in that hour period versus a quick 10 minutes. Okay, so that's something to pay attention to. How long did it take to get them out of that car? All right, I've had patients come to me, and I think I told this story in the video, that I had a patient come to me and he was like, they were on he was on a door and duct taped down to it. Okay, because that's what they had, and I think he was from a farm or a rural area, and that's what they had. Okay, so the question of under the influence. So I want to know their alcohol level. This is also something that gets really sticky for traumas, because you will have the cops come up and tell you that they want you to draw labs from them. Okay, and that gets really sticky on what's allowed and what's not allowed. And so just make sure you are very aware of your facility policies on if you're going to be a person that's in situations where you do blood draws, especially when you do like blood alcohol content blood draws and stuff like that, that you know what your facility policies are, because that can be really altering and really damaging. And you wouldn't want to go against someone's rights, but at the same time, you got to respect the law. I think there was a big video that came out where a nurse was taken out in handcuffs because she refused to do blood. Okay, so other things I see popping up are emergency contact. Hopefully, if someone's in a car wreck and they're being brought into you, they've got someone with them and they can be calling some family or calling 911 or doing what they need to be doing. Organ donor. Nice transition, that's perfect. We will talk about some organ donation. Okay, so let's talk about organ donation and how this goes. What's the difference? What's the difference between cardiac death and brain death?
Cardiac death when the heart stops beating, and brain death is when there's no longer brain activity.
Right. So cardiac death, or they call it circulatory death, is when the heart is no longer pumping. Okay. They call that DCD, which is I think death after circulatory death or something. And then brain death is when the brain's no longer functioning. That doesn't mean that the heart stops. Okay, remember, because the heart has those cells that like to be leaders. Remember, they do their own thing. So just because your brain's not working, your heart functions without it. It can be like, that's why it's just kind of crazy that way. So when we have organ donors, I will tell you now, I have never asked a patient or looked at a patient's driver's license to see if they're an organ donor or not, depending on how I'm going to save them. But what it does mean is that if we get a patient that is not going to survive, okay, something's happened to them, they've had a huge wreck. It doesn't even actually take a huge wreck. I've had people that fell off a bicycle and became organ donors. So it just depends on the place that they hit their head. But if you get somebody that's like they're losing, there's 3 core reflexes that we look for when we're looking for brain death. Gag, cough, and basically blink. Okay, or corneal. Gag, cough, and corneal reflexes. Okay. Cat. Sorry, she's attacking my feet. But so gag, cough, and corneal reflexes, those are 3 core and primitive protective mechanisms in our body. And so they will keep us safe. That's why we gag on things, is to protect our airway. That's why we cough, is to get stuff out of our airway. And we blink to protect our eyes, because we are visual creatures. And if we don't have our eyes, we can't keep ourselves safe from the saber-toothed tiger or dinosaurs or whatever we're running from, okay? So we have to have all 3 of those. That's why those core systems evolved in us. If we lose one of those, we have to call, I think it's called Live On now, which I don't like their new name. It used to be Nebraska Organ Recovery, but now it's basically, it's the organ donation procurement group that comes in. And so once we lose one of these, okay, or once we get an injury that we know is not life-sustaining, whether they're gonna make it or not, we called them. Like, the hospital has a protocol. If you lose one of these and you do not call them within the hour, the hospital like gets a check mark, like they get a bad grade, okay? And so many of those bad grades gets funding, federal funding pulled from hospitals. So they are really particular about, if they lose one of these, you start calling them. They would rather be on the case than, and have to sign off because the patient recovered, than to not be on the case and patients being ready, families being ready to take them off the ventilator, and them having to say, wait, they're a first responder organ donor. Which, what that means is that person has signed their driver's license to be an organ donor. So that's a first, I think called first person permission or something like that. I'll share a video. They gave me one here just a week ago, and I'll get it on there for you. I'll get it on Canvas for you guys to watch, so that they talk about kind of their side of it. But if someone signed that card, that's a legal documentation. It's a legal piece of documentation, and we can't go against it. It's the one thing that we cannot go against. Okay.
I got a question, Erin.
Yeah.
So I think somewhere I read that even if they said they are an organ donor, the family can refuse.
Nope.
Do you still have to get permission?
Nope.
No.
Nope. It's not like a DNR where the family can change it. Nope. It's the real McCoy. So once you've signed that, now they will not, depending on the patient, like if you're under 19 in Nebraska, then they do still have to get family permission because you're not an adult. But like my 19-year-old son, I know he signed his. He signed it. If something, God forbid, were to happen to him, he's an organ donor. Now, for say if something went, I was like, no, I don't want him to, they're gonna weigh the options. He's 19. He's got young, healthy organs. They're gonna take me to task. They're gonna say, this is what he wanted. We're going with his wishes. We're sorry, it's against yours. They're gonna do it really nicely, but they're going to do it. Here's the big thing for nurses. We are not allowed to talk about organ donation with families. We do not cross that line, okay? Why do you think it is that we cannot approach families for organ donation?
Maybe so it doesn't appear as though we're like trying to influence or sway.
Okay. So we don't want to pressure them into it. That's one. Why else?
You don't want to change your level of care.
Okay, don't want to change level of care. Think about what you would look like. Like you've got trust with that family. Think about what it would look like if all of a sudden you said, well, sorry, your loved one's not going to make it, but we can donate his organs. Like all of a sudden it's going to make you look an awful lot like a Grim Reaper, right? That you were never interested in saving him, that you were only interested in his organs. And so that's one of the big things. So we don't want to be the ones that are going to pressure him because we're their safe person. And we don't want to be the one that blurs that line either. Okay? So we do not ask people for organ donation rights. If they come to you and say, hey Kelly, I know my son's not going to make it. Do you think, what do you know about organ donation? What are you going to say?
Can I get them some pamphlets, or I'm still gonna say no?
We can say, what we can say is, let me get someone for you to answer your questions. Okay, we can absolutely get them resources. We can say, that's a really interesting question, or can my son donate organs? I took care of a young man that should never have come to us. He was a gunshot wound to the head, and we had wrapped like 4 ACE wrap bandages around his head, trying to keep the blood in because he was losing blood so bad. We were using bath blankets to soak it up off the ground. Like he was just pouring blood out as fast as we could push it in. And the only reason we were doing it was because his dad in the ER had said, well, can he donate his organs? Because he was a 35-year-old guy that got shot in the head. So he was like, can we donate his organs? And so then all of a sudden that ramps up all the care. Instead of being like, oh, we're getting ready to withdraw, as soon as that organ donation thought comes in, we're ramping care up. I know people think that, I've had a friend one time, really smart person, but really dumb at the same time. Because she goes to me, she goes, well, Erin, I'm not signing my organ donor card. And I said, oh, really, why? And she goes, well, because then the paramedics won't try and save me. And okay, in an emergency situation, do you think the paramedics are going to take time to try and find your wallet? Like, they don't give two shits about what you are. They want to save you, okay? Like, I just looked at her, I was like, I need another drink because this is going to get into a really long conversation, right? Because she was just like adamant about it. I'm like, no, trust me, paramedics, nurses, we don't care. We're going to try and save you. We're going to try and do our job. We're going to try and take care of you. And so, yeah, it was just this whole funny, like, huh? Okay, yeah, that's not what we're focusing on. The other thing is if we want your organs, we want them well perfused, well oxygenated, well functioning, okay? So I can't do that if I leave you dead on the roadside, right? We have to have you we have to have you intubated, we have to have you in the facility and ready to go. It also takes anywhere from 48 to 72 hours to get everything set up, okay? It takes a long time. Because you have to match people. Think of all the surgical teams you have to get ready to go. I saw an organ donation. I was lucky enough. I took care of the young man. He was like 17, just super sad situation. I'm not exactly sure. You know, you never know what the story is that you get that's true. But I took care of him, and I got he'd been working on his car, on like his stereo of his car, and he'd been up underneath the, what's that called? The stereo is, you know, he'd been working up underneath there. So they think he must have been like soldering stuff under there and basically gotten some sort of like inhalation injury and poisoning while he was under there. And he like went to his brother and was like, hey, I have a headache at like 1 a.m. His brother gave him a couple hydrocodone from like a knee surgery, and he went to bed and like never woke up. So, I mean, 17-year-old kid working on his car. His family went in at like noon because they were like, we haven't heard or seen from him. What the heck's going on? And so they went in at like noon, and he was agonal breathing. And so his dad started CPR on him, and they brought him in, and there was just nothing we could do to prolong his life. So we had him on a ventilator, and he was never, you know, I mean, he would have been a vegetable even if we'd been able to bring him back, but his head just looked, I mean, the CT was gone. So, but we have to run a bunch of tests for that. Like cardiac death is kind of easy. You do a stethoscope and you listen and there's no heartbeat and okay, you're gone. With brain death, we have to run several different tests to see. We run EEGs. We do this really cool thing, which is not really cool for most people, but you tie a tourniquet around their head and that stops all the blood flow to the scalp. And then we do a scan to see what blood flow is to the brain. And if there's no blood flow to the brain, nothing will light up. Other thing is, if you ever gotten really cold water in your ear before and how much that hurts, what we'll do is we'll take ice water and shoot it in their ear to see if they have any sort of twitches or reactions, to see if there's any sort of nerve or anything open. And so unfortunately for this young man, everything was gone, but so he got to donate all his organs, but think about everything that has to get lined up. So he was donating his heart, his lungs, his kidney, his liver, like everything, because he's 17 and he's a young kid. So he donates everything. That's 4 surgical teams, right? That all have to come to the OR at the same time. And the heart, last I knew, I think the heart was good for 4 hours. The lungs are good for 8. The liver's good for like 18. And the kidneys are good for like 48 hours. And what I mean by good for it means that they're good for that long from cut time to reperfuse time. So you have 4 hours from the time you cut out that heart to get it in the next person and get it perfusing. Otherwise, that heart is no longer good. I think they're having some changes. I can't remember, now they're starting to get some cadaver tissue, but I can't remember if that's heart or lungs. So that may be changing. They're always coming up with new ways of doing stuff, so stuff changes a lot. But it was really kind of cool. Like they cracked open, I got to be there for the surgery. They cracked open his chest. They used the heart to pump the preservative around the body. They sew that into the aorta so that it actually pumps the preservative around to the body to all the other tissues. But I mean, they opened the chest and there's a woman in scrubs like standing right next to me and she's looking over and I see she's on her cell phone. She goes, "Yep, it's good. Get her ready." And there was a 16-year-old girl in Arkansas that was getting a heart that night. So just kind of cool, you know, I mean, really sad for the family that's going through it, but kind of cool that he could save a life. And Live On Nebraska, they do a ton for the donor families. Like they do memory stuff, they do heartbeat strips, they'll record the heart and put it in like a stuffed teddy bear so they can hear it. I mean, just really cool. And I'm sure you guys have seen all the stories where people go and see the person that has their kid's heart or whatever, and they get to listen to it and stuff. So that's really cool and really heartwarming. But as far as we are concerned for our care, when it comes to organ donation, so last unit we talked a lot about the transplant and the recipient and kind of what they're going through, and now we're kind of talking about the donation part of it. For donation, we cannot talk to them. We cannot approach. We can tell them if they approach us, we can say, we'll get you some resources. And if we see signs that they are dying, like these 3, gag, cough, and blink, gone, or what they call corneal reflex, where we literally take a piece of like gauze and touch the eyeball and they don't twitch at all. That's something we have to pay attention to, and we got to call Live On and get them started. Other things we might see is just someone we know is not going to survive. Like the injury's too great. You know, like they may still have a little bit of gag or cough left, but it's not going to last much longer and we know it. Okay. Or we have someone, think about the drugs that we put people on that could give you these images. So we have to get them off all those medications and then still have no gag, no cough, no blink and stuff, and do all the brain testing. So it takes a significant amount of time to match, but really cool if you ever get the chance to see it. It is a little, I've worked both sides of it. I've worked liver transplant side where I've seen people get livers, And then I've worked the donor side where they've taken from the patient. So, so that's brain death. Cardiac death is a little different. So cardiac death, you have, I can't remember all the organs you can take with cardiac death. I know the liver and the kidneys. I can't remember. They're switching, they're slowly changing things. It's either the lungs or the heart that they can now take what they call DCD, which is death of circulation. But that's different, right? So they still have a little bit of brain left, right? They still have like maybe they have a gag, but they don't have a cough and they don't have a corneal reflex. But they're not going to have any survivable outcome. Like you take them off the ventilator, you know they're going to die. And they're not going to have a meaningful life, right? This is where it gets into that quality versus quantity. Are you going to give them, you know, you guys all went to Madonna. You've seen the people that are on vents there. Like, is that really what that family wants or that person wants? No. Okay, then we're going to take them off the ventilator. Now are we going to take them off the ventilator and donate what we can? So then we'll go in, and that one, they'll go down to the OR. And family can sit with them down in the OR. They'll get as much prepped and ready as possible. They'll take them off, they'll extubate them, and then they'll kind of wait. And they have about an hour. And they have an hour to die. And if they die in that hour, then they give them another 5 minutes. They call time of death. And then it's a rapid extraction. I don't think that's the right term for it, but a rapid removal. And so it's a really fast removal of all the tissues to get them out and to get them going and get them where they need to be. So, and then all those tissues have taken a hit because they've had a period of time where they haven't been oxygenated. So they've all taken a hit. And so that might change who they go to. Getting, like people that you can't buy organs. I know people think you may be on the black market. I've never seen a bought organ. You can't trade for organs, you know, so it's kind of interesting what people think. There's so much matching that has to happen before an organ can get transplanted in. So that's something to pay attention to. Okay. That I know there's a whole bunch of theatrics when it comes to that, but really you can't really buy organs because there's just so many matches. And then it's like it's ranges. So like Lincoln organs will go to like the Midwest, kind of Lincoln, Omaha, Iowa, Kansas maybe area first. And then if there's no matches, they'll go out further. And then, but think if that heart only has 4 hours, that's the furthest it can go. Like it can't go outside that 4-hour area. Okay. They can do organ donations from any place that has ICU or ventilators. I know I was talking at a conference one time and a lady talked about, she worked at Madonna and they had a patient that they were going to compassionately extubate and they had to stop. They had to take him to the hospital because he had signed his driver's license saying he was a donor. So they had to and that was really hard for the family and really hard for the nurses there because they never thought about it, but you have ventilators there. So if you're going to take somebody off a ventilator, always check with Live On Nebraska to make sure that they are not a candidate for donation. So you don't want to cross that bridge. And it's kind of funny that the Madonna nurses just never even thought about it. So does that kind of think about that organ donation piece of it? Okay, this is going to be somebody though that's going to be in ICU. Live On Nebraska is going to send someone to the facility to run the patient. The nurse is the general care person, is the person that's with them at the bedside. But then once they sign over care, they're the ones that do all the orders and everything. So kind of it changes the process a little bit. And our priority then doesn't become about turning the patient and the comfort of the patient. It really becomes about keeping those organs going. So we still turn them because it's good for the organs. We still do a lot of stuff, but it's all about keeping the organs well perfused. Okay, so that's something to think about when you're going into it. What do I want to cover? Make sure you guys get. That was on my list. Cardiac or head trauma. So we're talking about organ donation, and a lot of organ donations come from our head trauma patients. I posted some questions in the Muddy discussion board. I saw some people that answered them. I'd make sure you kind of know some of those things. ICP gets really, really important with our head traumas, at least when they're first brand new. But after that, like once we craniotomy, that is not as usually as big of a deal. Just because we've why do we do craniotomies?
Decrease pressure.
Okay, decrease pressure, right? Because I don't know if that helping me at all. See if that helps a little bit. I'm just trying to get ceiling overhead lights seem to cause a lot of reflection on whiteboards. So the nice thing about this head is that we have a protective skull. The bad thing about the head is we have a protective skull. Okay. So when we have injury to our head, it can't swell. Okay, and if it starts swelling, there's a big hole in the bottom. Okay, I don't know if anybody remembers their anatomy, but there's a really big hole in the bottom, and it's called the magnum foramen, about yay big around. If the brain continues to swell, and we do not stop the swelling, either by controlling ICP or by doing a cranie, it'll herniate. And we call it a brainstem herniation, and literally the brain herniates down the spinal cord. Okay, basically when that happens, you become an automatic organ donor. Okay, or at least you got to be on the phone call list, because there is no coming back from that. Right? I took care of a kid one time, sweet family. He had gone out partying with friends. He was like 20s. He was a university student. He went out partying. So I'm not sure exactly. The stories I got were about 5 different stories of where he hit his head or when he hit his head. He either hit it on a light fixture, he hit it when he fell down, he hit it when he got into his bed. I mean, the stories were just kind of funny but apparently he'd gone to a party, hit his head. But guess what? What do the symptoms look like when you've hit your head?
Probably something similar to being drunk or tired.
Right. Stumbling, slurred words, you know. Think about everybody you've seen on O Street at midnight, right? Pretty much what somebody with a head trauma looks like. Loss of consciousness, stuff going on. Pupil. I know all these shows always love to show pupils. Pupils are one of the last responses. If you're looking at pupils, you're too late, okay? Like I know my friend here, he's got, you probably can't see it, he's got one big pupil and one small pupil, okay? Too late, can't fix that, can't solve that, okay? So that's something to think about. And so when we're talking about head traumas, so when I go back to this kid, he hit his head, drunk. They got him to bed. No one could tell if he was drunk or had the head trauma. They put him in bed. Well, now it's like 4 o'clock the next afternoon, and apparently it's Sunday, and apparently he really likes football. And his friends noticed he wasn't out watching football with them, and they couldn't figure out what was going on. So they went into his room. And they woke him up, and he had slurred speech and was just not coherent. So his friends, really, really smart friends, scooped him up and took him to the ER. Okay, he gets in the ER, and what they found, they did a quick CT on him, and what they found was that his brain was starting to bulge down into his brainstem. Okay, so I mean, I can only imagine what Dr. Tomes was like down in the ER at that time, because apparently he did not make any bones about the fact that they needed to get him to the fucking OR now, or he was going to die. And I'm like, okay. And Dr. Tones is a little short, bald guy if you've ever met him. So it's just kind of funny. I'm like, I could only imagine how red and hot his head was at that moment. So they got him to the OR. They did a cranie on him. Okay, a cranie on him, take out the skull. Funny thing, where do they put that skull? When they take that skull out, where do they put it?
I laughed
In
so
the
hard
abdomen?
In the abdomen. Why do they put it in the abdomen?
because they kept losing it.
Because they lose them. That's the only reason. I know people think it's for blood perfusion and all this stuff. It's not. It's honestly because they lose them. Okay? So, because by the time we send people to rehab, they still have their craniotomy. They still have the skull removed. So, think about the patients you've taken care of that have had helmets and stuff. So, they stick it in the abdomen to keep it so that it stays with them. So, think about listening to bowel sounds.
Under just a couple layers of skin, or like how do they really
Just kind of do a little cut and tuck.
pouch to?
Yep, just slide it on in there. Yep, it's their own tissue, so they're not gonna have rejection issues.
I
Okay.
guess you won't have to be worried if they like get hit in the stomach.
Well-
No protection gear there.
I mean, it's just part of the skull.
It's
So-
weird.
With our head traumas, if they've had a shattered skull, those ones we're not gonna mess with trying to keep when you're trying to put all the pieces together. But if we can keep their own skull, it's better, it's safer, it's stronger. Okay. Something else with this young guy. So they get him down to the OR. At this point in time, once you've done a cranie, ICP is not as big of a deal because we don't have, I mean, the brain, like I could push on his brain. Okay. Because I mean, the skin's there, but there's no skull keeping it shut.
Did the brain ever swell kind of up and out of that hole? I mean,
Oh yeah.
you're like super high intracranial pressure, and one, as soon as you cut that open, it's gonna start one coming out, but then if it continues, it's just, I think of like Play-Doh toys.
Pretty much. If you've ever played with one of those little squeezy dolls where the eyes like bug out kind of thing, that's kind of what, yeah. But you could see like his brain was like swollen out.
Okay.
So from it, but
Before there's really any issue, I mean, depending on where it is.
yeah. Well, and then think about, we have signs everywhere that says, don't lay on left side, or, you know, left craniotomy, be careful, that kind of stuff. So it's really important that we're paying attention to when we turn them and stuff, that we're really careful that we don't have cords underneath that side of the head or something. Like, I mean, you wouldn't want that anyways, but we really pay attention to it because we know that there's nothing protecting the brain. And if you've ever played with Jell-O, that's about the consistency of brain. So it's really soft and squishy, does amazing cool things, but it's very soft. Okay. So this young man, he gets there, he gets into my ICU. Now, things that what do we do for swelling? What are simple things we do for swelling?
Cool.
Cool.
Cool it. Yep. So I'm going to cool him because that's something I really want to do, right? Because I want to get that brain as cool as possible. So we're putting ice in his pits. We're putting ice in his groin. We're going to cool him with the Intercool. I'm taking, this is when we talk about NGs. He has an NG down, and I am, let me mute you guys real quick. I'm going to put an NG down him, and I'm going to do gastric lavage, where I have a basin of ice water, and I'm sucking it up with my syringe, and I'm putting it down into his stomach. So he's getting ice cold water in that stomach. I let it sit there for 20 minutes, and I pull it back out and put more ice water down there. Okay. Complications that can happen from that. Big one is the loss of potassium and the loss of electrolytes, but we'll deal with that later. We've got to get the swelling under control. The other thing I did for him is I gave him a cold bath. So there was 2 reasons for a cold bath. One, he'd been at a party in college. What do people like to do to you at parties in college when you pass out?
Gross things, all sorts of things, anything, everything.
Penis and balls all over him. On his forehead, on his cheeks, on his everywhere on his body, right? His mom is coming from Minnesota. She will be here in 8 hours. Probably less than that at this point in time. So I have probably 3 hours to get him settled and cooled and get all the penis and balls off of him. Okay, so I'm scrubbing him down with ice water. I'm getting him cooled down. We're good. We get him down. We want him to the core temperature of about 31 to 33 degrees Celsius, which I think is about like 91 or so. I mean, we want him cool, okay? So we get him cooled down, so we get the swelling down. Mom comes in. He's doing okay. We've got him paralyzed. Why would we paralyze him?
To reduce brain stimulation.
One, to reduce brain stimulation. What happens when you get cold?
You shiver.
You shiver, okay? And so we do not want you to shiver because of that brain stimulation and the calorie intake. You're gonna burn through calories. You can't heal if you don't have calories, okay?
So you start getting rigor even with like deficient calorie?
Did he start getting what?
You start getting like rigor even with.
Not rigor, not like dead rigor, like shivers. Like shivering from being cold. So we don't want him to, okay, because that's gonna burn calories and that's gonna create more brain stimuli. So we don't want that. So we've got him paralyzed. We have him sedated. We have him on pain medication. We have him, so he's out. There's no, when we talk about gag, corneal, all that, he doesn't have any of that because we paralyzed him, okay? We have other ways of monitoring to make sure that there's still brain activity, how much we have to paralyze you. We have measuring tools for that, but that's not a big deal. So super funny, his mom comes in, it's probably about 5 in the morning at this point in time. She's been driving all night, just panicked and worried about her son. She comes in, I talk to her, I tell her, he's paralyzed, you're not gonna know, he is in a coma and we've put him that way. We want him in that way. She picks up his arm to hold his hand, and by golly, there's one left penis and balls like on the arm, and I'm like, fail. Okay, she didn't see it when I told her we were going to turn him at one point in time and had her step out, and I scrubbed his arm real quick. But so we talk about, someone brought up that decreased stimuli. Really, really important with our head traumas, we decrease stimuli. Okay, so when I talked to his mom and educated his mom, it was hold his hand, don't pet. Every time we pet, we stimulate every nerve we touch, okay? If I just hold, it's one area, one stimulus, done, okay? And that's really hard for moms. We really like to rub brows. We really like to touch our kids when they're in those states. It's really, really hard. So I did a lot of education with her of how to work with us. So ended up really sweet. So he never knew me because, I took care of him when he was in that critical state, sedated, paralyzed, all that. He never got to know me. But his mom and I took care of him for 3 nights. So his mom and I got really close. He ended up coming out of it and walked out of our hospital. So like just a really cool case. Very, very rarely do we ever see anybody that's starting to herniate that ever makes it, just because that happens so quick. Once they start herniating, it's usually dead and done, okay? So that's something that happened with him, really, really cool. He was a physical therapy student, so I don't know if he ever went back and got his physical therapy degree. Probably had a whole new outlet on life. But how long do you think we leave people cool for when they have head injuries?
I'm not entirely sure, but I was going to ask, with cooling them to that degree of being concerned about hypothermia, and then you're starting to fall the other way. So I guess I would think you wouldn't leave them in there very long. I mean, I don't know.
About 3 days, about 72 hours. And the big thing is remember, the body is kind of weird. It's really good about shifting. Like, we have to be really careful. We go down fast, but we come up slow. So it can take us 36 hours to get someone rewarmed, because we can't rewarm them fast. It'll cause shifts in electrolytes and shifts in balances. The other thing with head traumas, and we've talked about this a lot with electrolytes, really, really important that we're watching their sodium, because water follows sodium. So this is why, like, we had to argue in the hospital. The hospital came up with a stupid policy, which I still think is stupid. I think Madonna does it too, where you have to do, every med has to have a water in between it. You guys have probably seen this. It's really, really dumb for lots of reasons. I get the pharmacy people getting all upset about meds being mixed, but for us, it was really dumb and dangerous. Because if we say we give someone 10 pills and we give 30 mLs of water between each pill, plus, 60 on either end, prime it and flush it, all that, you're talking over 300 to 400 mLs of water. What kind of solution is water?
Isotonic.
What, Lakeisha?
Is it isotonic?
It's not isotonic, it's hypotonic.
Hypo.
It's below it. It's hypotonic, right? It's below. So remember what
I
happens.
knew it had an O in it. I couldn't remember if it was iso or hypo.
Yep. ISO is the same. Hypo is below, hyper is above. So with head traumas, this is why it's really important that we don't let them drink water. So like all of our concussion kids, one of the biggest things that I tell concussion kids is Gatorade. Drink Gatorade. Okay? Because I don't want their brain to swell any more than it already does. When we do hypotonic solutions, fluid goes in. Okay? So when we do a hypotonic solution, that is making me so mad. I'm totally going to be that teacher that gets mad at my technology. When we do a hypotonic solution, it goes into the tissue, okay, because we're hydrating it. So we really want to give either a hypertonic solution or we want to give an isotonic, okay? So that's why like all our concussion kids, man, I'm like, nope, Gatorade. I can let you do water every other one, but I'm going to make you do some Gatorade. And if it's better, I like to give you Gatorade with the powder because I can make it stronger, okay? Or I do the Gatorade that's powder because it's actually works. They've shown that some of the Gatorade bottles have sat there for so long, you don't know if the electrolytes are actually in it or not. So that's kind of an interesting one. So really important to pay attention to the electrolytes we're giving our head trauma patients. So you guys will see this if you work in long-term care rehab. I think Madonna has a bunch of head trauma patients. They do a lot of that specialized rehab for them. And so you'll get some of these guys where they may not be able to have much water, but usually at that point in time, you know, they're past the acute phase, so it's not as big of a deal. So, but something to always pay attention to when you've got, I mean, concussions are just so huge right now. Okay. Let's see. It's just asking, let's see, if the tissues take too much of a hit without being oxygenated. Oh, okay. It's back to the organ rejection or organ donation. If our organs take too much of a hit with lack of oxygen, we can't use them. So that's why like our kidneys and our liver, because they don't care as much about oxygen, I guess, they seem to perfuse really well. That's why they can sit on the shelf longer. Like your kidneys are good for 48 hours after you're dead. So we can do cadaver kidneys, we can do all sorts of things. As long as the kidneys were healthy when you died, like renal failure wasn't the reason you died. So kind of cool. Let's see. With head traumas, who of you guys, and you can do your little raise hand thing or just raise your real hand, have taken care of head traumas in rehab or somebody that's had a traumatic brain injury? Okay, Casey, Layla, Christina. Okay, what were some of their behaviors?
That I took care of, it was kind of like you never know what he's going to be doing when we walk in. So he can be very, very happy with her, and the next second he'll be stabbing us with a fork.
Okay.
I was gonna say mood changes were a lot of what I noticed, like very content and then all of a sudden very upset and depressed, and just a lot of mood changes happened with the person I took care of.
Yeah. So really, really moody. That even worse. Let's see if I go ahead and angle this way, maybe. I don't know. Anyways, really, really moody, not stable. I saw Asia staying aggressive, up and down all day long, impulsive. Okay, they can be really, really impulsive and just like, you just don't know. Yeah, you don't know what you're going to get when you walk in. So that can cause some hard times when taking care of them, because you just quite never know. You'll hear people say, oh, they're really frontal today. Our frontal part of our brain, first thing to know, is the last part of our brain that develops. Okay, our frontal part of our brain takes till we're about 25 years old to develop. So that's kind of an interesting thing when you think of like teenagers, and that they are moody and impulsive. Okay, because that frontal part of the brain hasn't fully developed yet. Right? And that's why it's really important. That's why young kids do dumb things, especially young boys. Boys do dumb things. Like, girls may be mean to each other, but boys do dumb things. So, but moody and impulsive are really common behaviors after somebody's had forgetful. Okay, they can be really forgetful. I told you that like 10 times. Get your shirt on. It's like talking to a toddler sometimes, when you're just like, I told you to get your shirt on. I told you to get your shirt on. Like, we're going down to breakfast. Let's go. So really, really interesting. I took care of, or I didn't take care of him, but at my son's school, they had a young boy that was riding his bike to school. And I live up here by Color Middle School on Vine. And this young boy was riding his bike to school, and a drunk driver at 8 in the morning hit him. And hit him to the point where like his bicycle got wedged underneath the guy's truck. And that's how they found the guy, was his truck was parked in his garage with the bike still wedged under it. And he was very, very drunk. So this young boy goes to the hospital. He's got a traumatic brain injury. I don't know if he was wearing a helmet or not. I'm not sure at that level of impact if that would matter, if he was wearing a helmet or not. But what was really interesting is this young boy survived. But I listened to an interview of the mom later, and she said, that man took my kid. This isn't my kid anymore. This isn't the same boy that went to school that morning. And she showed, like, he had to have lists in the bathroom, because he didn't remember. You couldn't just say, hey, let's get ready for school. He needed brush your teeth. And even, I didn't see how detailed the lists were, but sometimes the lists have to get so detailed. They have to be, open the toothpaste, put toothpaste on your toothbrush, brush your teeth. Stuff that we take for granted and we just do second nature while we're, doing whatever. He had to be retaught and relearned. And hopefully, fingers crossed, he's young. Hopefully he can regain some of those pathways. But it's really, really interesting how much of who we are is all here. And I would say 99% of who we are is all right here, okay? Because the people I've seen survive head injuries don't come back the same way. And I know they love to show that on TV. I know I saw senator or whatever that got shot at a rally, and she was back up and talking or something a year later. And I was listening to her speak, and I'm like, she's slurred. She's, you know what I mean? Like, maybe the cognition's still there, but she's different. And so I think people don't understand with head traumas, you're different. If you get a spinal cord injury, you're still the same person. If you were bad at coping before, you're still bad at coping, right? I mean, if you were funny before a spinal cord injury, you're going to probably be funny after a spinal cord injury or a broken leg or any of that kind of stuff. But if you get into a head trauma, that changes your personality. And so that's a really big thing. And that can be really, really hard for families. We had a little old lady, and she wasn't a head trauma. She was a stroke. But she never had said a cuss word in her life. And she had a massive, massive stroke. And she swore like a sailor, which was funny to us because we never knew her. We never knew Grandma before, who was prim and proper and never said a cuss word. And now she swears like a sailor. Like, to the point where they couldn't take her to a restaurant because she would cuss too much. And no one else is going to understand that. Like, we, again, think it's funny, but no one else is going to. So it can be really interesting. So, and Asia just kind of brought up that it's very similar to people with advanced Alzheimer's. And it is, because it's damage to the brain. So you can think about head trauma. And I know we've talked about like strokes and brought up Alzheimer's and all that kind of stuff. It's all damage to the brain. Okay, different. Stroke is from disease process. Trauma is from something happening. Okay, and so like, and usually it's an outside force. What do you think impacts trauma? Like what impacts survivability of a trauma?
Response time and
Okay.
how long it goes on for.
Right? So time is a big piece. What else?
The extent of damage, so maybe how much was affected.
Yeah, like the level of injury.
Okay. So extent or level of injury. Which one, time or level of injury? What do you think has a bigger impact
Time.
on outcome? So Misty, what do you think?
I think it's time because depending, they kind of go like, depending upon how much time, then it would know your next course of action.
Okay. All right, Christina, what do you think?
I also think time because like, well, I don't know. I think it's a mix of things, but I know it's just to choose one. I think more so time than extent, but I guess, you know, if your skull is completely bashed out, like, you know, there's probably no helping.
Right. So that one's a big one of extent of injury. Okay.
Yeah.
So there really isn't a right answer. Okay. This is just something to try and get you thinking about, like, how would I change what I did? How would I change? I took care of a young man who had gotten, him and his girlfriend were on four-wheelers, which, by the way, I hate four-wheelers because I cannot tell you how many injuries have come in from four-wheelers, and it just, they just make me mad because there's so much injury to them and people think they're safe and they're not. So with four-wheelers, people get on them. This kid and his girlfriend were on it. They hit something or flipped it. She flew far away, but he was under it. And so by the time, and now we're talking four-wheelers, you're not doing a four-wheeler in the city. You're doing a four-wheeler sorry, my dog decided to come say hi. So you're not doing a four-wheeler in the city, you're out in the country. And so there now you're talking about time. You're talking that this is gonna take a long time. So by the time the girlfriend, she couldn't lift the ATV, so she had to either call or go get dad. Dad comes out, he lifts the ATV off his son, and now he's doing CPR on him. Okay, so now he's doing CPR, and they do CPR for 45 minutes out in the field on this kid. Okay, now they get him into our hospital, and they get him to our hospital, and I mean, he's purple from the nipple line down, from what we would call a like hemorrhage response. Basically, all the like blood cell, like small capillaries on the skin ruptured from the trauma, but it was the nipple line down. And I remember me and a coworker have watched him roll in, and we're like, he's not getting out of here. He's not leaving here. And he ended up walking out of our ICU or walking out of the hospital, but he wasn't the same. The head trauma, the lack of oxygen to his brain for so long had caused so much damage that he wasn't the same kid. Like, he was not, apparently he'd been a real sarcastic kid and loved sarcasm and that dark humor, and he didn't have that anymore. So he lost pretty much a core piece of who he was. And hopefully, again, he's young, hopefully he'll get it back. So young age has a lot of impact on survivability, or at least outcome of the survival, you know. So that's kind of something else to think about. All right. What other questions do you guys have?
You talked about the types of brain injuries, like I can't even think of its name right now. It's a weird name. diffuse axonal injury.
Yeah.
Concussions are an injury. So like, I just kind of wanted to like, what was classified as a traumatic brain injury? Like, can we go over that?
Yeah. So with different types of brain injuries, let's see if I can get any closer. Sorry, guys. So we'll go back to drawing my skull here. Right. So you've got the skull, brain sitting inside. All right. So when we're talking about DAI, which is diffuse axonal injury, what this is this is a shearing that happens, but it's not a shearing that happens here. That's the coup counter coup. When that shears back and forth, that's that coup counter coup. That's that that whiplash effect. Diffuse axonal injury is those neurons, those little threads of neurons that are going through your brain, and they shear and they rip apart. And then they, as they disintegrate, then they also have like toxins that break down. And so then that causes even more problems. That causes more swelling and more damage. So diffuse axonal injury is little tiny dots of injury, microscopic trauma and damage to the brain. Okay, this is what leaves people in vegetative states a lot of times, because remember that core piece of the brain that has our blink, gag, and cough, it's fine. Okay, so I mean, it might still have some of this injury to it, but I call it the chicken brain, because that's the core part that's going to keep us alive. We're not related to chickens, it's okay. But that's just kind of what I call it, because it's that basic brain that just keeps us alive. This part is all who we are, right? And so this is that injury. This is what concussion injuries look like if we could see them, but we can't, okay? When I get a patient that comes in and they've had a head trauma, so like probably one of my worst nights in the ICU, we had 2 guys come in relatively close to each other, both beaten with 2x4s. So, and just beaten, their heads just smashed. And so that, no, that marker doesn't work. Peter, can you get the dog? Thank you. So that we're talking about, they have a direct impact somewhere. Okay.
Is that like your blunt trauma?
Yeah, this is our blunt force trauma. So this is our trauma that, I'm trying to get it nice and dark so you guys can see it. On my side, I can't see it very well. Yeah, I'm about to teach them about head trauma. Dogs.
Upstairs.
Okay, up, go. Layla, upstairs. You're fine. You're not in trouble. Get out of here. All right. So, otherwise they start playing tug and it's just all breaks loose. So, but when you're talking about your head trauma, so we've got diffuse axonal, which is that microscopic injury that we can't see. Like we cannot well, there's no scan for this, right? This is our person that's not waking up and we can't figure out why, or they've had a concussion, okay? But our blunt force trauma that's someone we can see, all right? We see someone that has an injury there. And what's really nice is it sounds bad, but it's nice in some way because we can take care of that. We can do burr holes in them sometimes, which is where we drill a hole in and release some of the blood and the pressure. We can, release some of that pressure from that. We can go in and specifically take out some of the matter and take out some of the clots and stuff like that. We don't do that very often because we increase the risk of bleeding and more trauma to the brain. But that injury is actually a lot easier to heal in some regard than this is, okay? So that's something that we really have to pay attention to. So you talked about concussions. This is what concussions are, and this is why they're so scary, because you can't see them. So like you can have a concussion and not see the damage, but you see the symptoms, okay? So what kind of symptoms do we see when we have either concussions or like all the way up, because it's the idea of a spectrum. of concussions due to accidental injury. Concussions being kind of the lower end, but you can have really bad concussions that add up to it.
Like slurred speech, inability to tolerate light.
Yeah, so let's see, here we go. So we can have light sensitivity,
Headache,
speech issues, headache,
loss of memory.
okay, memory issues, especially they don't have memory of the event. A lot of times with concussions, they don't have that quick memory there. So we have headache. That's probably a huge one for your concussion testing. That's why a lot
And
of people, Go ahead.
delayed symptoms.
Okay, they can
Like-
have delayed, yep. Yeah, they can have delayed symptoms because you're waiting. These little microscopic areas, they have to swell. And they don't swell a lot of times right away. They got to take some time for those toxins to build up, for the tissue to get irritated. Swelling's a process, right? Like that's why when you go and twist your ankle, you don't take off your hiking boot right away because you know you're not going to get that bad boy back on. The swelling's going to get worse overnight. Okay? So that's something, it can be very delayed. Vomiting. Vomiting's a big one that happens because it's kind of down in that core, in that nerve system. All right, so that's something we can really think about. Yep.
What's with the, if you think somebody has a concussion, you need to wake them up every hour, couple of hours. What's with that?
Okay, so one thing we didn't talk about, that's one of the big things for this, is change of LOC. It's change of level of consciousness. So if we have a change of level of consciousness, you know something's going on, okay? Especially if they just recently hit their head and they lose consciousness. There's something going on. That used to be, we didn't want people to fall asleep because what would happen? Your brain would continue to swell and you'd be dead and never wake up in the morning, okay? Now, we know the process better. We know the science behind it. The thing is we have to balance. When we talked about head trauma, we don't want a pet because we don't want to increase stimuli. If we wake you up every 2 hours, we increase, or if we're waking you up and don't let you sleep, well, guess what? You heal when you're sleeping. So if I don't let you sleep, you can't heal. And if I don't let you sleep, you now are stimulating that brain over and over and over and over again, right? So we have to think about, what do we do? Well, we let them sleep, but we wake them up every 2 hours and we check their assessment, because now if I can't wake you up, but 2 hours ago I could wake you up and now I can't, now I know, but I'm only 2 hours down that road, not all night down that road. Right? So like I'm catching it earlier. So that's one thing that we'll do. My daughter got a really bad head trauma at one point in time. I had gotten home from the hospital that morning and she was playing with her brothers, and she was 2 and they're like 8 and 10. So they played tug of war. Not a bad game to play. However, when you're on the 2-year-old side and everybody else is on the other side, and you're on the top bunk and they're on the floor, very bad game to play. So they tugged and she fell down, and I could hear when she hit that it was a different sound. Okay, when bones break, they make a different sound. And so I kind of was like, okay, I need to check her out. I'm a rub some dirt in it, you'll feel better tomorrow kind of mom. So you got to be like bleeding or close to death for me to take you to the hospital. She had a huge goose egg and black eye. And so I was like, okay, let's put some ice on it, blah, blah, do all that stuff. Well, what happened was, I'm tired. I want to go to sleep. And that's when I'm like, because that's change of level of consciousness, change of behavior. That's what made me think. And then she's like, holding her head because it hurts, but I expect it to hurt. But at the same time, I'm tired. I want to go to sleep. And so that's when I'm like, okay. So I scoop her up and I put her in her car seat and we go to the ER. And I live by St. E's, but I pass St. E's and I just go straight to West because it's the trauma hospital. Plus I work there. And I got nicely told by the doctor when I was there, like my 2-year-old, it's 9 in the morning. My 2-year-old is unconscious pretty much on my lap. And the doctor's like, oh, well, you know, when kids have a level of injury, high level of injury, or they have a surge of adrenaline and then they're just tired afterwards. And I'm like, she's not tired. I know my child. I said, she needs a CT. He ended up saying, oh, okay, well, we'll do a CT. And she ended up having a skull fracture that actually went in the orbit of her eye. So till about noon, she was asleep. She was out, and we would wake her up and she'd wake up and then she'd go back to sleep. So, you know your kid. That's one thing I would say is like when people bring their kid in and are like, no, something's wrong, pay attention. Because some parents want attention and they're going to do stuff and they're going to be over dramatic and all that kind of stuff. But most parents, I would say 90% of parents know their kids and they know when something's wrong. So I was just very much like, no, something's wrong. She's normally a very bouncy 2.5-year-old. So make sure you're always listening to your parents. So here's a question for you. How would you know? So we've talked a lot about head trauma. We've talked a lot about this. How would you know if you worked in a clinic? How would you know if a kid came in with a head trauma?
There's certain questions to ask.
Okay. What question?
Oh my goodness, I knew you were gonna ask that. The first question is, did you hit your head?
Okay. Did you hit your head? Yep.
Yeah.
But does every kid that hits their head have a head trauma?
No.
No, but kids hit their heads all the time.
We had a female softball player who got hit in the head with a softball. And so I asked if she felt dizzy or did she get sick, nauseous?
Okay.
Did she see, was her vision okay? Did she see stars, basically?
Okay, good.
So
what if they're 18 months?
Oh, then they can't really talk to you.
Right? All right, so let's go. Casey, how would you assess it if a 18-month-old, how would you assess a head trauma? Try and get other people who haven't talked.
I mean, their level of consciousness too, but I don't know.
That's one of those questions, like, guys, think about the different age groups, because like we've talked about, head traumas a lot of times look like people are drunk. Well, 18-month-olds often look like they're drunk, right? They're stumbling around. They don't have great coordination yet, look like that. So something to think about is, Asia brought up bilateral strength, definitely possible. Some weakness. Oh, seizures. If they start having seizures, definitely a worry. Christina, did you have something to say?
I don't know if I unmuted it. I would say seizures as well, just because like with my brother, but I feel like most importantly listening to like the parents, because my brother had seizures when he was little and the doctors and nurses were like, it's fine, it's normal, like what he's doing. And my mom's like, it's not normal. He had some type of injury to his head, so he's like mentally disabled, but they just didn't pay attention to that. They didn't see it, so they're like, it's not real.
Okay, so when we're looking at things, seizures are a side effect of something going wrong with the brain. Okay, so a seizure is really important to be paying attention to as a side effect of head traumas. Okay, I think Lexi brought up Glasgow Coma Scale. Yep, absolutely could do one. Do they respond to you? Do they open their eyes? What about with head traumas? What about the at what age do fontanelles close?
Fontanelles close later, I think.
Isn't it closer to like 9 months to a year or something?
Okay. So if someone had a bulging fontanelle,
that would let me know they have like a brain swelling.
Right. Because unfortunately, one of the kinds of brain trauma is shaken baby syndrome. Okay. That's brain trauma. that is head trauma. That is where cause some big issues. So if you're seeing somebody with a bulging fontanelle, they're usually going to be younger than 9 months. Okay, they're going to be young. But bulging fontanelle means we have brain swelling. Okay, the nice thing about little kids with head traumas is, one, kids are pretty pliable. They bounce a lot, right? I mean, kids fall all the time, so it's not uncommon for kids to fall and hit their heads. I've had many bruises and goose eggs on my kids' heads. But something to think about is different ages, stories. Okay, if the story doesn't match, if that story doesn't match because the mom said, oh, well, the baby rolled off the changing table. They rolled off the changing table. They're 2 weeks old. Do babies roll at 2 weeks old? No. They're like little sacks. You just put them down and they stay. They may cry, but they stay. Okay? It's great when you got to go do laundry because they stay. All right? They get to about 6 months old. Now they're crawling. Now they're rolling over. Now they're doing all this stuff. So it'd be really important to pay attention to the different developmental stages that come with kids. Because the other thing that'll happen with kids is their cry is very different. It is the freest, scariest cry that you could ever think to hear. It's this high-pitched screech when a kid has a head trauma, okay? And you're talking usually little. You're not talking, you know, an 8-year-old. You're talking like a 2-year-old. Their cry is just this high pitch, very different. And so that becomes a big issue with them, all right? We brought up seizures, so let's dive into some seizure stuff. And if I can find my video quick, I can show you some stuff. All right, so when we're talking about seizures, remember seizures are that there's something wrong. I think of seizures as being like a fib of the brain, right? Somewhere there's an electrical current going wrong. So things that we want to measure with seizures or how we diagnose them is an EEG, okay? Electroencephalogram, and that's how we're going to watch someone if we're trying to figure out if they have seizures or not. So that's something to pay attention to. What kinds of things would mess this up?
Could like electronics, like, or a cell phone mess with it at all?
Nope.
I'm just thinking of like interference.
Metal?
No. What do we all like to drink?
Alcohol.
Alcohol.
Caffeine.
Caffeine. Right? What are we all using to stay awake these days? Caffeine. Caffeine can really mess with an EEG. Okay, so that's something that we need to make sure. And an EEG, because it's an electroencephalogram, they're going to stick stuff to the brain or to the scalp here. Things like we'll have to tell people not to, you know, don't shampoo your hair, don't put conditioner and all that stuff in your hair, because we're going to have to go in there and put probes down on their skull so that we can really get a really good electrical reading. So it's like trying to get a EKG or ECG through the heart or through your clothes, right? We got to get down as far as we can. Think about like your hairy chest instead of your hairy head. So we got to get down. But people that drink a lot of caffeine, we have to tell them, hey, you can't have caffeine for like 24 hours, okay? And they do not like you a whole lot when you tell them that. The other thing is the anti-seizure meds. They may need to be off their meds for a while, because with an EEG, we want them to have a seizure. We want to see it so that we can see where it's happening, and then they can go into the brain and they can do just the same things they do for AFib. They can go in and do an ablation. They can go in and like try and kill an area that's causing that seizure to happen. There's a lot of other things. People have probably like the deep vagal nerve stimulators and stuff, or we can go in and get them to get rid of their seizure by sending an electrical current to kind of counteract it. So that's kind of cool. But we might have to tell them to not take their meds for a while. 24 hours without their meds. So they might have to be off their seizure meds for a while, which some different seizure meds, okay? Ativan, Depakote. There's some others out there. But those are kind of our big ones that we're gonna get people on. Valium is another one. All of your PAMs are good anti-seizure meds. Usually your Ativan's one we're gonna give fast for someone if they need to have some medication. Depakote, we have to watch. They get really bad teeth with Depakote. It causes hypergingival tissue. Basically, their gums like overgrow with it, so we have to be really careful. There's some other ones. I think Thorazine is one. Barbiturates can be taken for it. So there's just a ton of different meds. One that's not legal in Nebraska, I saw Keppra. Marijuana is one that we're seeing a lot. Okay, so, and this is one, you guys, I mean, this is coming. Let's just be honest. I know we're in Nebraska and we're in a really conservative state, but it's coming. The Med Center wants marijuana legalized so they can study it, because they lost a lot of their seizure kids to Colorado as soon as Colorado legalized it. So I don't know how well marijuana works, but I mean, I think we're going to start seeing some really good research about it for working for this.
There's an interesting thing, because my brother has worked in the industry for a really long time. How a lot of people, they never really thought, but if you take anti-seizure meds, how you need to be careful if you go and smoke marijuana, because it can interact with your meds or vice versa, and then potentially render them less useful, which I thought was just a really interesting point that I haven't heard of yet.
Yeah. So, I mean, that makes sense with, I mean, a lot of our drugs are interactive with marijuana or alcohol or any of those kinds of things. So always making sure that one of the questions we ask people is what street drugs do you use? Any non-pharmaceutical approved medications, So Asia's showing me Keppra is another drug that we have. Keppra and Depakote, the same thing. Can't remember. Like Nimitop. So here's an interesting thing. What if your patient's NPO and these are their meds? What do you do if your patient's NPO and these are your medications?
I mean, do they need meds?
What?
Can you do IV meds?
Okay, can we switch them to IV? Definitely a possibility to look. Okay, what if we can't?
I mean,
Is there other alternatives?
Okay, other alternatives. So definitely Ativan we can switch to IV. Keppra, I can't remember if that one's IV or not. I'm trying to think. I just had a patient actually when I was on spring break. I took care of a guy who has, I think they said he has like up to 10 seizures an hour. But his seizures are they're kind of little ones. They're not the like big seizures that we think about. So he has a bunch. He'd been off his medications for a little while. We were getting ready to do an EEG on him, so that's one reason we wanted him off. But we actually were going to try to start getting him, but he couldn't swallow. He had aspiration. And so we couldn't give him his meds because he couldn't pass his swallow study. And so now we've had not given him his meds for about 8 hours. I don't think the nurse, I was actually retraining to be in the ICU because of all the COVID stuff. And the nurse that was training me, I don't think she liked me very much. But because I was like, can we not do some other things? Like, can we put an NG down him? Like, let's go. Like, we need to get these meds on board. Because what happens, say you have a patient who has a small bowel obstruction, right? And we know small bowel obstruction, we have to rest the gut. And they haven't had these meds. And they haven't had these meds for 3 days. And you just keep holding him because he's NPO, right? We just heard NPO, NPO, NPO. What happens? You've taken him off his seizure meds, his anti-seizure meds. What's going to happen?
He's
He's gonna have seizures.
Right. That's what happened. Okay, guys, like the nurse didn't call the doctor to say, hey, you realize this patient's NPO, and this was a different patient. And the nurse didn't call and say, hey, you realize this patient's NPO and we haven't been giving him his meds, but no one's let the doctors know. And so the doctors think he's just getting his meds because they're doctors and they just don't pay attention. And then that guy has a massive seizure. Why are seizures bad in the first place?
Do they mess up neural activity?
Okay.
It stops
Message neural
oxygen
activity.
flow.
Oxygen, right. You can't breathe. Depending on the type of seizure you have, you may or may not be able to breathe during it. Okay? Breathing is kind of important to life. We kind of like to keep people breathing. All right? So, really big issue. A patient was not given their anti-seizure meds for several days. They ended up having a massive seizure and ended up dying from hypoxic brain injury because nurses didn't give the anti-seizure meds. Okay, and then nurses then didn't. Now, it's smart, nurses couldn't give us the anti-seizure meds, but the next step is you have to tell the doctor. You have to understand what your drugs do. The nurses didn't understand. He was given a drug that they were not familiar with, so they just kept holding it. Whether they were new grads or not, I don't know. I think it was Nimitop that they hadn't given, and that's just not one people are real familiar with in their brain. And so the patient ended up having a massive seizure and ended up dying. He was in for like a small bowel obstruction, and now he died, massive seizure and hypoxic brain injury. So really important if we have seizure patients that we are giving them their medications, and if we are not giving them their medications, that the doctors are aware. And it's really important to cover your butt and chart. Doctor aware, not giving medication, no new orders received, or see new orders, or whatever you need to do, because you do not want this on you, because a doctor is not going to say, oh, well, they told me, you know, and if there's no charting on it, the doctor's going to throw you under the bus before they throw themselves. So make sure that you chart anytime you call a doctor or anytime you hold a med, especially if you're holding it. If you hold it once, probably not a big deal, but if you're holding it for several days, you need to be calling that doctor and making sure that they know that you're holding it. Okay, and they may say, well, that's not my drug, you need to call so-and-so, or you need, doesn't matter, follow the pill, follow it where it goes, and make sure the right people know so that you're not going to get in trouble for that. So let's talk about, we want this patient to have a seizure, right, because they're getting an EEG. We want to see it. We told them not to take their caffeine, we told them to make sure that they're not taking their meds. Okay, what kinds of things do we want to watch for, or what kinds of things are important with seizures?
How long they last.
Okay, so time.
Interventions you give,
Okay, what kind of intervention? I want more than just
like turning them to the side so they don't aspirate, maintaining safety for them.
okay, so safety. So we've got our aspiration, right? So we want to keep them breathing. And
No hitting head.
yeah, decrease trauma.
Apneic periods.
Okay. Right, we like people to breathe. So if they're not breathing, we better be paying attention to that. So here's my big thing when it comes to seizures is we had this lovely little gentleman who was on hospice. And a nurse charted that he had a grand mal seizure. So what's a grand mal seizure?
Isn't it like your classic seizure where they're actually seizing, the whole brain is like lit up?
Yeah. Grand mal seizure, everything's going, massive convulsions, the whole kit and caboodle, right? That is a grand mal seizure. Nurse charts, patient has grand mal seizure, calls family, says, just so you know, he had a seizure tonight while we were taking care of him, and I just want you to know he's on hospice, so we're not going to do anything, right? Because we know he's dying for another reason. But when he has no history of seizures, never had a seizure before, hasn't had one since, and it's been over 24 hours. And seizures are not typical with dying. Like, it's not like, you know, we see fever go up, we see, you know, apneic periods with dying patients. This is not a typical thing. It's not like everybody has a seizure at the end of life, right? So I go and talk to this nurse, and because I'm the supervisor, and I just want to know, and because all her charting says is patient had grand mal seizure. And then after it, she says, patient woke up, wanted crackers and cheese. What's peculiar with that?
I mean, if they're on hospice, one, like you said, having a seizure is odd, and then I feel an appetite at all is kind of odd, but okay. But then having an appetite like that, I feel right after a seizure, I would question being like, okay.
Right. So there's a little period after a seizure called post-ictal.
They're usually super tired.
Yeah. A seizure is like running a marathon, okay? And they are exhausted after a seizure. All of your muscles have contracted. You're exhausted. Now, again, it depends on the type of seizure. Like if you have an absent seizure, those are a little different. You're gonna be, you're not, you're just kind of blah afterwards, but you could still have an appetite for some cheese and crackers. After a grand mal seizure, never had a history of having them. So what I went to her and asked her, I said, tell me about his seizure. What happened? And she said, well, it was 2 a.m. and we went in to turn him and put him on clean pads. And when we turned him, he straightened his arm out and got real stiff. And I'm like, so you went in it, so I'm like, let me clarify. You went into his room, you pull, after he's all snuggled in at 2 a.m, you pulled off all his blankets, so now he's cold, shocked, and then you turned him, exposed him, and wiped him with cold wipes. I go, it sounds more like he tried to brace himself or catch himself than having a grand mal seizure. So the reason I tell this story is not because the nurse was obviously not the brightest bulb in the bunch, but it was more because don't chart big fancy words. Chart what you see. If she had charted at 2 a.m., staff went in to clean patient. When we cleaned him, he seemed to stiffen up and his arm got stiff and he was not really responding to us. And then after we got him all cuddled back up and, covered up and all that kind of stuff, he wanted cheese and crackers. That doesn't sound like a seizure to me. Same event. But that doesn't necessarily sound like a seizure to me. That sounds like maybe you shocked him and he was just kind of startled. Maybe more of a startle reflex. So, but now you've got family from Texas flying up because their dad, who's on hospice, who's never had seizures, is now being told they have seizures. Don't diagnose. Chart what you see. Chart what what you did, okay? So, big thing, time, safety, and apneic periods. Were they able to breathe? Are you going to be able, will putting oxygen on these patients help them? No, because if they're not breathing, it doesn't matter if you put a leaf blower of oxygen next to them. They are not going to breathe until everything is ready. Now, it's really good to put oxygen next to them so that as soon as they take a breath, they take full oxygen, but don't be expecting them to breathe sometimes during a seizure. Okay, other things that are really important, so we talked about post-ictal, is that after period, they're really tired. They may not have a whole lot of memory of what just happened. The other thing is beforehand, they may triggers. They may have triggers, things, but they also may have what they call an aura, where all of a sudden they get like, I've heard of people getting like a metal taste in their mouth. So they just get this metal taste in their mouth and like, oh, metal, and then they know. And what's really nice about that is they can get themselves to safety. I took care of a young lady who was just who was in her car, and she ended up having a seizure and running into a street pole. And so they bring her into us to the trauma unit, and we do everything we can for her. And she ends up not making it because we can't save her. Like there's just too much damage to the brain from the seizure, and then the trauma that went with it. And so it's really interesting, families' perceptions, though. A little side note on this one. There was a huge, and when you're reading all this stuff about COVID-19, take everything with a grain of salt, because like in the Journal Star, there was this huge write-up, a full page, because, you know, when I say she didn't make it, what I mean is she was pretty much brain dead, but she still had some of that core chicken brain left, so enough to keep her digesting and heart pumping and stuff, but she was on a ventilator, she was on a trach, she had no blood flow to her brain. We trach pegged and sent her to Madonna. And eventually she kept bouncing back and forth between Madonna and the hospital because she would keep getting septic because her brain was decaying and all that tissue was dying and then causing her to be septic. And so they would dump in a bunch of antibiotics and send her. It was like playing hot potato with, everyone knew she was going to die except the family. And it was playing hot potato with her until she ended up dying finally at Madonna. But what was interesting is there was this huge full page write-up in Lincoln Journal Star about the fact that she was communicating through her foot. She was tapping with her foot. And it's like, no, I've seen the scans. There is no function left in that brain. The brain is literally decaying and rotting. So there's nothing. Sorry for people that are eating dinner. So, but, you know, I mean, so it's really interesting. So seizures can have huge, huge impacts on people. So we want to make sure that we're paying attention to what triggers them so that they can be safe, because we don't want people to get in car wrecks when they're having or get in their car when they're having a seizure, right? We want them to be safe, so that if she had known her trigger, she could have pulled over and gotten safe and then had her seizure, or called 911 and had her seizure. So really cool. There's dogs that are seizure dogs that they can tell when you're going to have a seizure, so they will like push you down or try and sit on you or something. And so it's kind of cool. They can dial 911. I met a person who had a dog that could dial 911. I was like, dang, I can't even teach my kid how to do that. That's impressive. So, so we're talking about seizures, big things for nurses. Chart what you see. Don't interpret it, just chart it, okay? There's a lot of people out there that like to chart those big fancy words. That's fine if you know them. If you can sit on the stand and defend that word, that's great. But if you don't know the words, chart the simple ones. Got really stiff in the left arm and extended it and stuck it out, and I couldn't get it to come down. Fingers contracted in, you know, not, oh, they had a localized left arm seizure with contracture. Great. No one knows what that means. Okay. Like just chart what you see. The other thing, time. How long was it? If we've got a really long seizure, we've got some big problems because we've got a lot of airway issues then, and that breathing piece of it. Safety, keep them safe. Do we put a spoon in someone's mouth? No, no spoons. Everybody's like shaking their head. I love it. No spoons. No leather straps. No, like whatever you see in the old movies. Make sure you make sure you're nothing in their airway. Guys, they have a clamp pressure like nobody's business. Do not stick anything in their mouth. It's kind of funny. It must have been a seizure week over spring break, because I took care of another girl who had a seizure, and she bit down on her tongue, and her whole tongue swelled outside of her mouth because it was so swollen and damaged from how much she bit on it and caused that tissue damage. So her whole tongue was like black and like sloughing. Again, sorry to people who are eating. So
why do they sell bite wings then?
I don't know what bite wings are. So,
you know, or like it's like a thing you put in the mouth to kind of compress the tongue so that it doesn't roll back into the airway.
That's more for airway protection. If we're doing something for airway protection, then that's after the seizure. Then you might, because then they're in that post-ictal phase and they again aren't protecting their airway, but they're not actively having a seizure. Because you can still like, break your teeth and stuff on mouth guards and stuff. So, but if you can show me, I can definitely, if you can show me like a picture or something, but a lot of times, and that could be for somebody who, like, again, if they know they're going to have a seizure, maybe they can put something, but even then, now you've put something in your mouth that could go down your throat if you don't have control over it. So don't put, like, as of right now, unless you're working with someone and a doctor tells you different, or a family does, don't put anything in someone's mouth. So it's hard to watch. Because you think, oh, I could put something in there to keep them safe, but it ends up causing more problems in the end. So, any other questions? We had some really good questions today. I was worried we wouldn't go the whole 2 hours. So, make sure you guys are looking in that muddy thought area for the discussion board. Also, if you've got questions, post them in there. One, I look and post stuff, but also like your other classmates can answer questions for you too. So use that space to, if you're asking questions. I know Asia posted a question for me here about the medications, and I can make sure I send that out. Yeah, I'll probably post that in the muddy discussion board part. So I might also post a video of, I've got a really good video. I was going to pull it up, but I don't know if I can find it quick. I can't find it quick enough. Of a little girl having a seizure. Be really careful if you go to YouTube for seizure videos, just to like look and practice, because some people are pretty sick and twisted, and you can trigger your kids to have seizures. Like they've got some kids that they like blow in their face and it triggers them to have like an absent seizure. I don't recommend triggering seizures, but this one video I have is a really nice one because the mom says in it that she's recording it to show it to the doctors, because it is hard to describe, and if the doctors don't see it, they don't always believe it. You know, they think that mom is like making something up. So I will find that video and I'll post it in that discussion board spot, so you guys can kind of practice timing it and practice like, okay, how would rate how well that mom did on it.
Erin, I have just a quick question, if I could, before we go. Yeah. Like, what about like the disclaimers, like on video games and stuff now, like that it can bring on epileptic seizures, like the lights and the blinking and flashing and the anime and all that stuff?
Yep.
Is that just triggering something?
Yep, because what that is doing is that is triggering stimulus to the brain, and it's so much stimulus going so many different directions that the brain is trying to catch up, and it can't always figure it out. So that's kind of the.
No, is that just like a? I'm sorry. Go ahead.
No, you go ahead. Go.
Is that like something that's just like a one-time thing, situational, or is that something that it will continue from that point? Just that one exposure that happened to cause a seizure could then bring.
Well, and a lot of seizures, like there's so many different weird disorders when it comes to seizures. Like we all kind of know epilepsy, but there's all like there's like all these different epilepsy-like issues and stuff. And a lot of, anytime we have like a brain tumor, a head trauma, a stroke, anything that caused damage to the brain now puts you at higher risk for seizures. So if you have a kid who's gotten a ton of concussions, they're now at higher risk for seizures. There's febrile seizures, which are seizures that are triggered by temps and fevers, and usually you see those in, little kids. Usually those are in little kids. You know, usually like I would say 5 and under. I don't totally quote me on the age, but like that's usually who I've seen them in, is usually even younger, usually like 18 months seems to be where I've seen them, but I'm sure 5-year-olds can get them too. But people seem to grow out of those. You don't see adults having febrile seizures, and not that it can't happen, but, so it's whatever triggered it. And so most likely if you've got somebody who has a seizure because of bright lights and all the flashing and stuff, that's going to be somebody who knows they have seizures, you know, who has some sort of seizure disorder, and that stimulus, that overstimulus to the brain is a trigger.
And that's why they have to give essentially the disclaimer?
Yeah. Yep. So they can't go on cool fun rides or Halloween haunted houses and all that kind of stuff because there's too many flashing lights and it's too much stimulus for them. So.
Okay, thank you.
Petra?
Aren't seizures, I mean, we all know, like, you know, the grand mal seizures and the ones where people are actually seizing, but can't they be, I don't want to say like mini seizures, but it can present differently as even just staring off into space or like having a tic or something like that?
Yeah, so there's localized seizures, which are a specific area of the brain that then triggers. And so like that's the person that will have like, you'll see them have like a twitch in their arm or something, or they'll have like a face, so something will happen to their face. Absent seizures are the ones where people they're like gone. They were like, woohoo, hello, are you there? And they're gone. A lot of kids have absent seizures. That's the ones they seem to do the most. I've seen on YouTube that just are twisted and wrong because they blow in their face and get them to do it. But so that's just something to think about. It's just, again, it's like AFib of the brain, but the brain controls so much more. It's the whole nervous system that's all over our body. So you can have somebody that has just a seizure of the leg. And that's why it's really important for us to document what you see. You know, that's why it's like, I'm not saying it's a localized seizure. I'm saying I'm seeing them jerk their left arm back and forth and all their fingers are contracted down. And they did it for 2 minutes. And then afterwards they were really tired. And most of the time though, people through seizures won't talk to you. I've never really had anyone talk to me through a seizure or be able to respond to me during a seizure or even really remember anything during it. So I had one time I was with a student at St. E's and we had a patient there and she was having seizures, which we were pretty sure were fake seizures. That's what's really hard about them is you can't always tell. And so I'm pretty sure she was having fake seizures, which we call pseudo seizures. And so we went in, and so she never had them unless someone was in the room with her, which was kind of the ironic piece. Like as soon as you'd walk in the room, then she'd start having seizures, and you're like, oh, okay. And so I went in, and if you've ever taken a marker or a pen and cranked it on your fingernail, it really freaking hurts. Okay, and so I did that to her while she was having a seizure because the student's like, oh my God, every time I go in, she's having a seizure, and I'm like, okay. So I went and did that to her. And then the next time the student went in, she goes, tell your teacher, if she ever does that to me again, I'm going to punch her. And I'm like, okay. Like, real nice. Like, yeah, you're not having a seizure, honey. Like, people are really good though. Like she would get the full face droop on one side and start going into it. She was good. But there's just a lot of mental health that can come with seizures. And so I'm probably a little crass with them. I don't necessarily believe people have seizures as much as I think I've seen. I think they're just a lot of attention getting. So, but there are people with genuine seizures. There are people with genuine issues that have documented cases. And that's why that EEG is really important because we have to be able to see the seizure. If we do an EEG on you and you said, oh, well, I had 3 seizures while I had it and we didn't see it on there at all. It's like saying you had a heart attack, but we never saw it on the EKG or ECG, so.
That's like the only way to diagnose seizures is to see that as it's progressing. So right. If you like a kid that you suspect might be having, one of those, I don't want to say smaller seizures, but anyways, one that maybe doesn't present as loudly or as obviously, is that just something you track the symptoms and then go to your doctor and they're just going to have to kind of figure out a best way to catch it in the act?
Yeah, and that's why it's so nice now that we have video cameras and people can pick up their video camera, their phone real easy and record, because so much was like parents telling, well, my kid keeps just blanking out. Well, man, if you said that to me, I'd be like, okay, that's half my kids half the time. So, there's a difference between an absent seizure and somebody that's just zoning out. And so you can see that on the electrical current, on the pattern in the brain. So it's kind of cool if you ever get to see an EEG. They're neat because there's so many different waveforms and we know a lot about them. So it's kind of cool to see, you can tell when somebody's in sleeping or thinking or creating, there's different electrical currents for all those kinds of things. So toddlers have different electrical currents. They're up in the gamma a lot of times, which is where we right above the gamma is alpha or whatever, and it's where we get angry. So it's crazy to see toddlers kind of run right under that anger wavelength. So different emotions and reactions are different wavelengths, and they know all that stuff. That's really smart people. They get paid a lot more money than I do, and so they can interpret all these different wavelengths then and see where different things are coming from and that kind of stuff. So, but it's hard. Seizures are a hard disorder to have, and I can't imagine having it. So I think that would be really scary and really hard.
I have a dumb question. I don't know if I've actually never worked with anybody that's had seizures.
Mm-hmm.
So most seizures, can like after the seizure, can they be managed at home, or do they have to go to the doctor, like the ER or anything like that?
Well, it just depends. It depends if there's somebody that's had, like the first time you have a seizure, you probably need to go to the ER or the doctor, because we got to figure out, are you having a seizure because you have a brain tumor, or are you having a seizure because you have some sort of epilepsy or some sort of issue? And we have to figure that out. And then we got to, and then we come up with different treatments. The treatments for seizures is all like the safety, right? We talk about seizure precautions. So like, the padded bed rails, making sure we have suction set up, making sure we have oxygen ready in the room. Those are all seizure precautions that we have for patients. But the seizures can become from different areas. You can have kids that have seizures, and that's how we discover they have brain tumors. And so then those kids never had a seizure before, and all of a sudden they have one. It's like, oh, okay, let's scan them. They have a brain tumor. We get the tumor out. They never have a seizure again in their life. So that's something we just have to figure out the why. But once people I don't know if you guys have seen, and I know we haven't been at school for a while, but they have the I think they're called Voices group, which is the kids that are they're through LPS, and they're the ones that wipe down the tables, and they come in and do the recycling and all that kind of stuff. Several of those kids have seizure disorders. And so you'll see the people work with them. I think we had one young lady just not too long ago. Well, I mean, we were in school, so it feels like long ago, but, and she had her aura where she's like, I've got the metal taste in my mouth. And so they laid her down on the floor in the middle of the cafeteria, and it was just prepping for her seizure. And then I think she ended up having one, but it wasn't very big. And we didn't call 911. We called her mom, but we didn't call 911 because she has them, I think, weekly. I don't think she's a daily person, but she's definitely a weekly person. So she has them frequently. The staff knows how to work with her and that kind of stuff. So they're scary the first time you see them. But usually the family knows. And that's one thing that's really important. If you do come across a kid that's at the playground or something, and all of a sudden they're down and they're having a seizure, look for those bracelets, because they'll have the epilepsy bracelet. And then at least, okay, this is a kid that has epilepsy. If no one's around, I still need to call 911 and get help. But at least we know this is a kid with epilepsy, and so this isn't just a seizure out of nowhere. So maybe we just need to adjust their meds and get them altered a little bit. So, okay. Any other questions? I'll be honest, this was way more fun than my all-day conference with people that were looking at ceilings and not actually engaging people and talking, or asking questions. So hopefully it was kind of fun to do the poll everywhere questions, just something a little different to do, a way of responding. So make sure if you have further questions you're asking. We're going to start on shock and burn next week and start attacking those. And then we'll kind of spend that last Monday kind of putting it all together of, we went through a lot of stuff. What do you guys really need to know about this information? All right. So have a great night. Stay safe. Go play in the snow, whatever. Go get some dinner if you haven't. So, all right. Have a good night, guys.
Thanks, Erin.
You're welcome.
Thank you.
Uh-huh.